It's okay. Thank you very much. Of course, I am honored and pleased to be here again, speaking in front of you. Now, I am an endocrinologist, and I'm sure, as many of other colleagues in other specialties, you will think that I observe the world through a lens of hormones, which is true. But hopefully today, with my presentation, I will try to show you that the vessel wall agrees with me, at least on this part of view of things. So why does this matter, and why should it matter to you as vascular surgeons from a surgically point of view? It matters because the vessel wall is not a passive structure. It's not a static structure. It's an active metabolic and endocrinological tissue which under certain factors can develop inflammation, can develop endothelial dysfunction, and that surgically translates in poor outcomes. So not necessarily the success of a surgery is only on the technical point of view, but also on the biological environment of the vessels. So that means that even in a perfect surgery, sometimes that perfect surgery can fail. Now, this diagram is only to show you shortly the pathophysiology overview of what I mean by metabolic and endocrinological factors, because I'm sure you're all used to terms like hyperglycemia or insulin resistance, dyslipidemia, and so on. But high cortisol, thyroid dysfunction, and very importantly, high PTH are a lot of time overlooked. And they're very important. Why? Because they can lead to oxidative stress, they can lead to inflammation, they can lead to calcification and endothelial dysfunction. So basically that means there is an imbalance between the protective side of view, the oxynitric side of view, and the inflammatory side of view, which translates into endothelial dysfunction and, of course, a clinical impact of restenosis, graft failure, or thrombosis in your surgeries. Now, I mentioned a little bit the PTH or parrot hormone. Why I'm emphasizing this? Because high PTH, I mentioned here secondary hyperthyroidism because I'm sure that many of you face chronic kidney disease patients, dialysis patients, and so on. But even in younger patients, this can be the case. So you will have a calcium and phosphate imbalance, which will lead, of course, to vascular smooth muscle cell transformation, which will become osteogenic. They will comport themselves like bone tissue, and you will have arterial calcification and stiffness. It's important to keep in mind that you're not operating on normal vessel tissue, you're operating on a calcification tissue. Now the next slides are very, I'm very fond of them. Why? Because we are talking emerging therapies. That means modern therapies. We are looking into the future, we're looking into modern state of medicine. And modern therapies, they don't treat symptoms only. Okay, we are talking SGLT2 inhibitors, we are talking GLP-1 analogs, we are talking peptides, and so on. They go deeper and they go onto the vessel wall. So they can lower, if we're talking SGLT2 or sodium glucose cotransporter type 2 inhibitors, we are well of them. They're used in diabetic patients all over the world, but they are being demonstrated to also have an effect on vascular tissue and vascular health. So we can say they're a metabolic therapy, but with direct surgical outcome. GLP-1, I don't know how it is in Egypt, but back home they're on the talk of everyone right now for obesity treatment, of course. But indirect, the weight loss will lead to indirect vascular benefit and to lowering the major adverse cardiovascular events. They are even introduced in the European Society of Cardiology guidelines for certain type of patients. Now, anti-inflammatory targeting, this is new state-of-the-art research, and there is a very interesting trial, the CANTOS trial. It was in 2017. They were looking for the effect of canakinumab, which is an IgG monoclonal antibody, to see the effect on atherosclerosis pathology. And they found that they could lower the cardiovascular events even without modifying the lipid numbers. Okay, so that was very important, and they demonstrated the inflammatory hypothesis of atherosclerosis. Peptide-based therapies, my favorite slide. Why? Because peptide-based therapies, they don't act like regular drugs. They go straight on the endothelial point of view, yeah? And they can, adrenomedulin is particularly interesting because it does vasodilation, it lowers the smooth muscle proliferation, it lowers fibrosis, it lowers inflammation, but apelin, it is extremely important in angiogenosis and in regeneration of the vessels. So basically they're used to see in the future how can target with these molecules the revascularization therapies. Now, what I wanted to keep in mind from this slide is that we are moving along. We are moving from the paradigm of just treating blocked vessels to biologically repair them beforehand. I already talked about hypercalcification. I don't need to insist on this, but you should have an endocrinologist on your side. Of course, microRNA, stem cells therapy, nitric oxide donors, all very important. They are now being investigated. They are in the early stages, but they should be kept in mind because once we have endothelial dysfunction, protection is not enough. We need to have regenerative therapies by our side. Now, clinical clues, I will just go very shortly through them when you have to pay attention after all our talk. When you have unexpected surgical outcomes, okay, early restenosis, graft failure, so on. Think endothelial dysfunction, think metabolic endocrine imbalances. When you have a disproportionate disease severity in young patients, in rapid progressions or multi-territory, think again genetic, metabolic, or undiagnosed endocrine disorders. If you have extensive vascular calcification, rock-hard arteries, difficult clamping or suturing, diffuse calcifications, think secondary hyperthyroidism, especially in older people, dialysis people, or chronic kidney disease patients, but not only. There's a calcium phosphate imbalance there. Poor healing, think diabetes, cortisol excess, so important. Also malnutrition, again, endocrine dysfunction. You can check, of course, systemic clinical signs. A lot of specialty surgical doctors, sometimes they don't look at signs of hyperandrogenism, signs of hyperprolactinemia, the galactorrhea, and so on, and red flags, of course, amenorrhea, low BMI, chronic stress. Always refer endocrinologist. What all of this leads to a better patient selection, of course, improved graft patency, and a shift towards personalized vascular care, because all modern medicine is shifting towards a personalized care for our patients. And this is what I want to take home. It is metabolic and endocrine. The endothelial dysfunction is a central driver of outcomes. The hormones affect the restenosis and graft failure, and the emerging therapies target biology, not just anatomy. And this is the future. Surgery plus optimization on a biological level. So better biology, better surgery, and better outcomes. Thank you.